Hello and welcome to a special interview for The Wire supported by Glenlivet Books. With Afghanistan dominating the news, it's quite understandable that it's wiped everything else from the headlines. But as a result, the attention that should be focused on COVID has also sharply diminished. And arguably, COVID remains the biggest problem India still has to tackle. Joining me now to talk about the big COVID picture facing the country is the chief scientist of the World Health Organization and the former Director General of the Indian Council for Medical Research, Soumya Swaminathan. Dr. Swaminathan, let's start with the big COVID picture, and after that, I'll come to other issues as well. The last 7-day average of daily cases in India is now just under 32,000. It's roughly 12% lower than it was the week before. The R number is also said to be around 0.9. Do these two together suggest that after plateauing for several weeks at the 40,000 level, India may now slowly be exiting the second wave?
Thank you, Karan, for having me on your show. And I think when we see globally what is happening, there are many regions in the world where things seem to be plateauing at a certain level, at different levels. In some countries, plateauing very high, in some countries at a more moderate level. So perhaps we are entering some kind of a stage of endemicity where there's low-level transmission or moderate-level transmission going on, but we're not seeing the kind of exponential growth and peaks that we saw a few months ago. As far as India is concerned, that's what seems to be happening. And because of the size of India and the heterogeneity of the population and the immunity status in different parts of the country, in different pockets, it is very, very feasible that the situation may continue like this with ups and downs in different parts of the country, particularly where there are more susceptible populations. So those groups that perhaps were less affected by the first and second waves, or those where there's low levels of vaccine coverage, we could see peaks and troughs for the next several months.
Now, one state where there is still concern is Kerala. Kerala still seems to account for 40 to 50% of the national daily toll practically every single day. Newspapers report that the positivity in all 14 districts of the state is over 10%. And yet, despite that, the 7-day daily average of cases is also declining. And the Times of India claims that for the week ending yesterday, it's fallen by 10%. So how do you view Kerala? Is it a state of concern, or is it also side by side showing signs of improvement?
Any state where you see continuing high levels of new cases and a high test positivity rate would be of concern. So I would be concerned. However, we also have to keep this in the context of how much testing is happening, what kind of testing strategies are being used, and also what the outcomes are. What are the hospitalization and death rates like? And if you look at all that in a composite way, then it appears that yes, there's ongoing transmission in Kerala. There are quite a lot of cases. I think over the last week, I understand that testing rates have reduced. Perhaps it's to do with the Onam festival and so on, and the test positivity rates are up. So I wouldn't go too much by the drop in new cases in the last week. I would wait and see what happens in the subsequent weeks and whether that's a sustained trend. The fact remains that they're able to manage the cases that they're finding very well. So perhaps they're testing earlier, finding more cases, and the case fatality rates continue to be extremely low, which is encouraging. They've had the lowest case fatality rates, I think, consistently from the beginning of the pandemic. They do need to do more to vaccinate more rapidly. They're one of the states that have high levels of vaccine coverage. Obviously need to expand that further and also take other measures to curtail transmission.
So in other words, what you're saying is Kerala is a picture we need to keep watching before we come to any sort of conclusion. At the moment, there are both signs of concern, but also one or two initial fledgling signs of improvement.
And the one other thing I would always keep an eye on are the variants. So the genomic sequencing, we need to look at, particularly in areas where there seems to be either continued high transmission or a new surge happening. because just like the Delta variant came upon us, we need to ensure that we're not caught by surprise with another variant. So I know the INSACOG is monitoring and tracking that, but I think we can expand that and even increase numbers further.
Now, one of the issues of concern, and I'm sure during your stay in Chennai, you've picked this up, is the question, will there be a third wave? When will it happen? How long will it last? And most importantly, how intense will it be? But I want to begin by asking you, is there any clarity that we can ever have about a third wave? Or is it all a matter of hunch and speculation, fortified occasionally by clever mathematical modeling?
So I believe no one has a crystal ball, and so it would be impossible for anyone to predict when, where a third wave will be upon us and whether at all a third wave will come. However, you can make an educated guess based on some of the variables that we know have an impact on transmission. And these are, what's your background level of population immunity, what, in natural infection and vaccination coverage, how is your public health measures and personal protective measures, how compliant are people with the protocols, that everyone is familiar with today, how much social mixing is going on, and of course, unknown factor, new variant. If any of these change, or if all of them change in combination, which is what happened during the second wave, we had all the three factors playing up: low vaccination coverage, lots of social mixing and mass gatherings, and a new variant, the Delta, resulted in exponential growth. That's what we need to be watching and monitoring. And at the earliest signs of any of these things going in the wrong direction, take action, localized action, containment, shut down, and do not allow these things to spread beyond a certain point.
I remember at this point what you said in answer to my first question, that some sort of stage of endemicity may possibly have started in India. You said it's very feasible that we may continue like this with small ups and downs in different places depending upon local conditions. Does that suggest that if there is a third wave, it may not be nationwide, it may be local and regional? And secondly, the highs may not be as worrying and as exponential as they were for the second. We may see much lower highs and much more easily manageable.
That's what I believe we are likely to see. But we can still get surges which overwhelm health systems, particularly if we start talking about smaller towns and villages. There, even a few hundred cases could overwhelm the local hospitals. So we shouldn't underestimate the impact or the human cost that even these small outbreaks can cause. And that's why I think it's very important to continue to strengthen the health systems, make sure that there's oxygen and all the essential materials, that staff are trained and prepared, that there's testing, so that even if there are these localized surges, people can be taken care of. I think, what do we want really? We want to prevent death. We want to prevent severe illness and morbidity and mortality. And so if we're geared up to do that, then we can actually live with ongoing infection, which is what countries like the UK now, which are living with quite a high rate of new infections on a daily basis. That's not costing them human lives. And so that's the stage we need to get to.
Now, against the background of what you've said, I want to put to you that yesterday, a team of experts appointed by the National Institute of Disaster Management, a government body that comes under the Home Ministry, has forewarned the government that the third wave will peak in October. And secondly, that amongst the worst affected will be children. And my question is a simple one. Is there any scientific basis for predicting or forecasting that children will be the worst affected in the third wave? This issue came up 2 odd months ago, and Dr. Paul debunked it at the time. He rebutted it. But since it's come up again, I want to put it to you. Can one scientifically predict that children will be the worst affected in the third wave?
Well, if you use the logic that vaccination started with the oldest, most vulnerable groups and is coming down. Of course, in India, people over 18 are eligible for vaccination, but we did have the initial period where people over 60 and people over 45 were being prioritized. Then you're left, as vaccination progresses in these groups, it's the younger populations that are going to be the ones which still have not been vaccinated. And therefore, with ongoing transmission, it's quite possible that also with increased testing in children, which we didn't see last year, that you will start diagnosing more infections in children. There's much more awareness now. Whole families get tested. If you look at the ICMR Sero survey, which is very interesting, of course, it's a representative sample of less than 30,000 people, but still gives you a snapshot. As many children as adults were infected in terms of proportion of the population. And if you look at 60% of India's children were infected over the last year and a half. How many were hospitalized? How many died? It's a very small proportion. So I think we can take from that the message that we've learned from other countries also, that while children do get infected, children can transmit. Children luckily have very mild illness most of the time. There is a small percentage that gets sick and get inflammatory complications, and a few will die, but much, much, much less than the adult population. So I think we have to look at it. Yes, children will maybe the ones that we are diagnosing more infections in because adults are getting vaccinated, but that doesn't mean that they are going to get sick, but it's good to prepare. I think preparing hospitals for pediatric admissions, pediatric intensive care is going to serve our health system well in any case for other illnesses that children have. So we should do that in any case, but I don't think we should panic about, thousands of children crowding into the ICUs.
We shouldn't panic about thousands of children crowding into ICUs. I'm simply underlining it so that parents are aware that children may get infected, children may also transmit to their elders, but children themselves are very unlikely to fall seriously ill. And that should be a note of assurance to parents that don't get unduly worried. Now, the government, according to several newspapers, has begun to stockpile a list of 15 medicines with the third wave in mind. They believe these could be critical if there is a third wave. Two of the medicines on that list of 15 are remdesivir and ivermectin. Now, those are two medicines that the WHO has explicitly said do not play a useful role in tackling COVID. You've actually advised people against taking these. So tell me, as the chief scientist of the WHO, but also as the former Director General of the Indian Council of Medical Research, how do you respond to the fact that your country is investing presumably sizable sums of money stockpiling medicines that the WHO says are not going to be of great use?
Yes, well, what WHO can do is to stay on top of the data and the evidence, promote research, and review the emerging evidence periodically so that we can update our guidance. We always keep an open mind. And if new evidence emerges, even if it's against what we said before, we have to update it. Science changes, we need to change our policies based on science. But as of now, there is no evidence that either hydroxychloroquine or ivermectin have any role to play in either reducing mortality or morbidity in people who've been infected with the virus, or actually in preventing people from getting the infection. And therefore, there is no grounds on which we can make a recommendation to use either of these drugs for treatment or prevention. And I understand the latest guidelines from the Ministry of Health and Family Welfare that were developed by the DGHS a few months ago, in fact, just in the middle of the second wave, do not recommend the use of either of these drugs.
And you include that remdesivir, don't you? You're including remdesivir. You mentioned hydroxychloroquine, but you're including remdesivir as well, aren't you?
So the Solidarity trial first phase showed that remdesivir does not reduce mortality. It may have a marginal benefit in a subgroup of patients who are ill enough to need oxygen, but not ill enough to be on ventilation. So there may be a marginal benefit, maybe, but certainly remdesivir does not do much at the stage of hospitalized, moderately or severely ill patients. And it's also very expensive. So one also needs to look at the cost benefit of interventions. A drug like dexamethasone and oxygen, these are the two essential ones that will save lives.
So given the WHO guidance, stockpiling remdesivir, which is actually a very expensive drug, and ivermectin simply does not make sense. And yet newspapers have announced that these are two critical drugs on that list of 15.
I haven't seen the list and I don't know what it's based on. So, I cannot comment further on that, but I am aware of the Ministry of Health guidelines that I saw a few months ago. And if that's still the most up to date, then I think certainly does not recommend ivermectin. And if I remember, it recommends the use of remdesivir very selectively.
Okay, let's come at this point, Dr. Swaminathan, to vaccinations. Given the very high infectiousness of the Delta strain, and given that the Delta strain is in fact the dominant strain in India, what percentage of the adult population needs to be fully vaccinated? So India, like many European countries today, can begin to feel reasonably secure. I stress the word reasonable in that. And I'll tell you why I ask. Because it's now increasingly clear that India is not going to meet the government's target of fully vaccinating every adult over 18 before the end of the year, both because we are unlikely to have sufficient doses, but also because we are unlikely to reach the required vaccination rate.
Because we're now dealing with the virus, the Delta variant, which is so much more transmissible, we need to have a higher proportion, a larger number of people in the population with immunity against the virus. And I think herd immunity, I don't think we do have a complete understanding or a definition as far as this virus is concerned. But what most scientists believe is you need upwards of 80-85% coverage in the population in order to really put a brake on transmission. But we're also seeing from countries that have high coverage and still have breakthrough infections that the currently available vaccines do not prevent infections completely. What they do is prevent severe disease, the pneumonia and the morbidity that ends you up in hospital. And so we need to keep that in mind as well. We also have to keep an eye on new variants. So if you look at the other side, what countries like the UK and Israel have achieved with high rates of vaccination coverage is a dramatic reduction in hospitalization and deaths. And so that's really our goal now, is to get to that level of coverage where you've vaccinated at least all the vulnerable people in the population, so that even if infections continue to happen, people are not ending up in the hospital very sick. It passes off as a mild infection. So our goals to achieve as high as possible, as quickly as possible, we should continue. And we should make use of all the vaccines that are currently approved by the WHO and in India to achieve that goal.
Let me put it like this. I'll cite the UK as an example. As of yesterday, the United Kingdom had fully vaccinated 75% of its adult population. I'm talking of the adult population, not the national population. And they have single vaccinated 87% of the adult population. India's figures are way, way lower. India's only done 13.7% fully vaccinated in the adult population and 48% single vaccinated. So would you say that when India approximates the UK figures, which are still short of 100% vaccination of the adult population, but at the UK level, India can begin to feel secure in the way UK feels secure today and begin to open up and begin to lead a normal life as UK is trying to do?
We're still learning about immunity, Karan. And so it's very difficult to put numbers and figures. India had a massive, massive second wave. And if, again, going by the ICMR Zero survey, upwards of 60% of people were exposed and have antibodies. Now, data that's coming out of studies, we know that even a single dose of vaccine after natural infection can give you high rates of protection. And of course, if you get the full course, then you get very high rates of protection. There's a very interesting study starting in the UK now, which we should see results in a few weeks, where they're going to look at people who've recently testing PCR positive. They're going to collect blood and look at antibodies against the S protein, but also the envelope on the nuclear capsid protein. That study is going to tell us about natural immunity versus vaccine-induced immunity. What happens when people who've been naturally infected then get vaccinated and vice versa. And of the all the people who are testing PCR positive, what sort of antibody profiles are we seeing? It would be very nice to see data like that from India, say, for example, from people who are being hospitalized currently or diagnosed with PCR positive COVID, to see what their vaccination status is, what their previous infection history is. We start getting a better picture then of, what our immune response is like to this virus. And also, of course, we need to understand now the duration of this kind of protective immunity, especially when different vaccines are being used.
Can I interrupt?
So a lot more research is needed, is what I was trying to say, to understand in the Indian context.
But if and when, and I'm using both those words, if and when India approximates UK figures of 75% of the adult population fully vaccinated, can we at that point, even though it's not 100% vaccination of the adult population, begin to feel secure the way the UK is? Because I know that the government's target of vaccinating every adult fully by the end of the year is now close to impossible, and I've explained why. So when we reach UK levels, would you think we could feel reasonably secure? Could people begin to relax in their minds a bit?
Yes, I would think so. Because we've had some natural, we also have this natural exposure that many people have had. It's possible that this could arrive even before that. But I think, to be very confident, I would say that once you have 75% of your adult population vaccinated, you can definitely be comfortable.
One matter of concern is that studies done by Public Health England as well as by the CDC in America have shown that the viral load of the Delta virus in people who get infected after vaccination can be as high as the viral load of the Delta virus in people who get vaccinated without infection. Doesn't that suggest that our vaccinations are not very effective at preventing the spread of the Delta virus? They will be good at preventing serious disease, but when it comes to spread of the Delta, they're not very good at preventing it, which is why the viral load is high, regardless of whether you get infected before or after vaccination.
Yes, that's right. None of the vaccines that are currently in use provide what we call sterilizing immunity, which means complete protection against infection as well as against disease. What they do is prevent against severe disease, which is excellent. And they have very high levels of protective efficacy. Even 6 months after the beginning of vaccination in countries which started in December and January, we're still seeing high levels, above 85-90% protection against hospitalization and death, even against the Delta variant. I think what would be fantastic is to look more at mucosal immunity, because what the vaccines we are currently using, which are injected, do is stimulate systemic immunity, IgM and IgG antibodies and T cells. If we also had vaccines like the nasally administered ones, which we could use to stimulate local respiratory mucosal immunity, then perhaps we'd start getting to the point where we could prevent infection and prevent severe disease. And I'm very happy that there are at least 2 intranasal vaccines that are in development in India, going into clinical trials now. And perhaps in the future, we'd have a combination, or you could boost with intranasal vaccines after a course of systemic or something like that.
One more question about Indian vaccines before I come briefly to this bigger issue of vaccine equity. The Zydus Cadila DNA vaccine, apparently it's the first of its type, has been given emergency use clearance by the Indian government, both for adults as well as for children over the age of 12. But it transpires that even now, after that clearance is given, its phase 3 trial results have not been made public. Do you find that surprising that a vaccine is cleared for emergency use, but its phase 3 trial results remain effectively secret?
Definitely, we would like to see the results more than just, the figure of 66% efficacy against symptomatic infection that we've seen. What has happened in the past, even with other vaccines, even in other countries, is that emergency use authorization is given by the regulatory agency because they have access to all the data, even though it's not in the public domain. So the expert committee has obviously seen the data before they've approved it. But what would be nice is to see at least a more detailed, if not the full publication, then a much more detailed results from this trial, because that will tell us the efficacy, what the confidence intervals are. So, 66%, but what's the confidence intervals around that number is something we'd like to know. We'd like to know its performance across different age groups and across people with underlying comorbidities, and particularly in children in the 12 to 18 group. It will be very important to see that. We want to know about side effects, and we also, of course, want to know, longer term data as they continue the follow-up, particularly since it's the first DNA vaccine that's now received emergency use listing.
For the sake of the audience, I'll point out that the reason why confidence intervals are so important to know is because they will determine whether the efficacy, which is a sort of midpoint between them, is a realistic one, or whether the confidence intervals are so wide that 66% figure is not as convincing as it sounds without the detailed background. That's why it's important to have the results, because then you know precisely how reliable and convincing 66% is. Have I summed that up for layman properly?
Yes, it gives you the confidence. So if you have 66% with a bound of, say, 55 to 70, you're very confident then that the 66% is a truly representative. You can have faith in that. If, on the other hand, the confidence intervals range from 10 to 90%, then the true efficacy could be anywhere between those two figures. And so the WHO, when we put out the target product profiles for vaccines way back in April 2020, we said we want to see a minimum of 50% efficacy with a lower bound of the confidence intervals not below 30%. So we are hoping that this vaccine would also fulfill that.
Now, the Director General of the World Health Organization has said that plans to give booster doses to people who are already fully vaccinated at a time when the vast majority of the world hasn't even had one dose are immoral and unconscionable. But the truth is, it's not just countries like the UK, US, France, Germany, and Israel that are determinedly going ahead with booster doses. There are even fairly loud and credible voices in India that are calling on the government to give booster doses to the elderly, to the vulnerable, and perhaps specifically to health workers. As the chief scientist of the WHO, but also as an Indian, how do you respond to these voices in India?
Well, I would respond to the voices anywhere in the world, because the WHO's policies are all based on data and evidence. And we have to follow the science here. And we shouldn't preempt the data by taking decisions which are then hard to roll back. That's what I'm afraid of. That if all the high-income countries, so one or two of them, start doing boosters, everyone else will follow. And then we will never know whether boosters were really needed or not, in which subgroup of people they might be needed. It's quite likely that, yes, the elderly would need boosters at some point, but do they need them 8 months, 1 year, or 2 years after the primary course? Do you need them sooner if you have variants which are breaking through the vaccines? And different vaccines could be performing differently. So you might need them for some vaccines earlier than others. So there are a lot of these factors, and that's why you need the studies. And we recently had a big scientific expert group meeting at the WHO to exactly discuss this point of boosters. The consensus was that we don't have the data and the science to make those recommendations. I'm distinguishing now the third dose for immunocompromised people, because there's clearly data there that some people who have advanced HIV infection or are on transplant therapy or anti-cancer drugs who do not develop good antibody responses do so when you give them a third dose. But that's a third dose in the primary course of vaccination. So that's distinct from saying, let's start giving a booster jab. And I think in India, our priority now is to first complete the primary course of vaccination. Only about 12 or 14% of our adult, I think it's about 14% of the adult population, about 10% overall of the country has received the second dose, the complete course. So we're still a long way off from completing that primary course in all our adults. So we need to get to that point, but at the same time, do the studies to see, okay, is immunity waning? Which groups is it waning in? So we need to follow cohorts to establish that, so that next year we'll be in a position to make a policy of boosters based on real evidence.
So the main point you're making is that as of today, We do not have the data, we do not have the backup science to justify that there is need for a booster dose. And even the countries in Europe and America or Israel that are determinedly going ahead are doing so without the data. They're doing it because they have other reasons to believe which are not data specific, because they want to guard against perhaps the fear that it could spread again. But the data that would justify scientific giving of boosters is still missing. We must wait for it.
Yes, we must wait for it. And, the countries that are doing it based on data that antibody levels are waning after a few months, that more symptomatic infections perhaps are happening. And this is being particularly observed, in the very elderly, in nursing homes. And also the fact that to protect against a Delta variant, you need higher levels of antibodies. So they're putting all those bits of evidence to say it's maybe a good idea to give boosters. But our argument, the WHO's argument is, shouldn't our primary goal now be to save lives around the world by making sure the vaccines get to places where people who are vulnerable still haven't had their first course? So let's use available vaccines we have today to prevent people from dying from this infection. And then we can get to the point where we want to boost, so we actually start reducing transmission.
So there are two strands to the WHO position. The first is the one you began with, that there simply isn't the data at this moment to justify giving boosters. Let's wait for that data, then work out whether they're necessary or not, and also then work out for whom they're necessary. But the second strand is a moral strand. When the vast majority of the world's population haven't even had one dose, there is something very questionable about giving third doses to well-protected people and ignoring those who are too poor to afford even one. We should concentrate on equity in that sense, because at the end of the day, no one is safe until everyone is safe. And we cannot compartmentalize the world and say we're going to write off large parts of Africa and Asia because we will live on our own in a little cocoon or a bubble in America or Europe. That is therefore the moral strand of your argument.
Exactly. So there's both strong scientific and moral and ethical reasons for not rushing into boosters. And yes, as you said, no one is safe until everybody is safe. And this may come back to haunt those countries, because you're allowing, by uncontrolled transmission in some parts of the world, the possibilities of a new, more deadly variant emerging and coming back to infect, populations of high-income countries is a possibility. So it also would be in self-interest of countries that have excess doses now to send those doses out through COVAX to countries which really desperately need them.
We're coming to the end of this interview. There's one more issue I want to raise with you, Dr. Swaminathan. There is a view gaining, I suppose, acceptance all over the world slowly, that the best we can achieve is to reduce or convert COVID-19 from epidemic status to endemic status. And in a sense, in your first answer to this interview, you suggested or you hope that process may have started in India. And the way to do it is to learn to live with the virus through vaccination, through COVID-appropriate behavior, and hope that over a year or two, the virus will be no more dangerous, no more lethal than the influenza one. Do you incline toward that view, that moving from epidemic to endemic status is what we must try and strive for?
Yes, I do, because I don't think at this point any of us are reasonably thinking about eliminating, let alone eradicating this virus. I think what we can reasonably hope for is that it becomes like any one of the other coronaviruses, respiratory viruses that cause some infections every year, but don't result in the huge amount of impact that it's having on people, on the health system, on the economy in general. So this is getting out of the pandemic phase into the endemic phase. And this is the right time to really start thinking about that, because we will need for some time, I think, to practice these COVID-appropriate behaviors, till we get to that point where we're very comfortable that this virus is not going to disrupt our lives anymore. So for some time to come, we've had disrupted education, all over the world. Livelihoods have been lost. Other essential health services have been badly impacted. So to get all of those things back, we will need, as we ramp up vaccination coverage, to start thinking about how these other sectors are going to function, where we have to minimize risk and harm. So it's a question about knowing and managing the risks even as we open up. And so if we continue the focus on public health surveillance, make sure we continue to test, ensure that people still follow COVID appropriate behavior. And this, of course, is difficult, but we have to keep reinforcing those messages and do the vaccination as quickly as possible. Then I think we could be in a good position quite soon.
A quick question. How many years away are we from achieving endemic status? I mean, is it something that one can foresee, or is it still so far down the road it's hard to guess? 1 year, 2 years, 3 years, maybe more?
Yeah. I would say that in a year and a half to 2 years, we'll be in that position. I hope by the end of 2022 that we would be in that situation where we have achieved adequate vaccine coverage. The WHO is calling for 70% coverage in all countries by the middle of next year. And if we can do that, then I think countries should start getting back to normal.
And as part of the process of reaching that state of endemic status, how important is it that we should have things like vaccine passports that determine whether you're permitted to mingle in public in large gatherings or visit public places where other people are? Are vaccine passports a sensible measure, or do you think, as many people in Europe and Britain in particular believe, that this is an infringement of people's rights and liberties? Which of the two?
So again, one has to balance public health versus individual rights and freedoms. But more important than individual rights and freedoms is, do you have an equal chance of getting a vaccine? I mean, have you had the opportunity to have your vaccination? Because if you've not, if you live in a country where you've not had that opportunity, then it's very, it would be very unethical to have guidelines based on, so-called vaccine passports, and the WHO does not support this term in any case. We do not believe that vaccination should be a prerequisite, at least at the global level, to be able to do things like traveling, because we haven't given everyone an opportunity to get vaccinated. There's so much inequity in access to vaccines. So the first thing is to get rid of that inequity. Then you can, and we do think that you can allow people who've been vaccinated and who have the proof of vaccination to, you can relax certain measures for them, like the quarantine requirements, for example, because that again is based on evidence that your likelihood of being infected, and again, these things are changing with the Delta variant and other variants, but overall, you can say a fully vaccinated person who's also taking other precautions is much less likely to get infected, and therefore maybe can skip things like quarantine, which some countries are now allowing. So there are two things. One is using a vaccination status to provide certain flexibility, certain freedoms, perhaps certain advantages, but not making it mandatory for people to have that vaccination in order to do certain things. But again, it's very difficult to generalize this, because if you're in a country where there's a free supply of vaccines, and the only reason you're not taking a vaccine is something that you believe in, then perhaps they're right in giving you these incentives, because it's good to have everyone vaccinated. And that's what many of the countries in Europe and the US are doing, giving lots of incentives to people. But this doesn't apply everywhere.
And that is the important point you're making. Vaccine passports, if you're going to have them, arguably could make sense in countries where the vast majority of the population is vaccinated, and it's only a small minority, for reasons of personal preference or prejudice, are refusing to get vaccinated. But in countries or for populations where the ability to get vaccinated is absent because they don't have vaccines, there to impose the need for vaccine passports on them would be to discriminate, because they don't have the choice, and yet you're excluding them on the grounds that they haven't been vaccinated, when in fact they may want to be, but they don't have a choice because they don't have the vaccine. So it depends upon which people, which country, what circumstances.
Yes, exactly.
My last question, sorry, please go ahead. You were about to say something.
I was just saying that for global travel, for example, we're recommending that every country accept all WHO EUL vaccines as proof of adequate vaccination. For example, when you want to skip, allow people to not quarantine and so on, and not have different rules in each country. It makes global travel very complex.
My last question, and in a sense, it follows exactly what you said about global travel. When will the WHO include Covaxin as one of its authorized vaccines? There must be about 100 million people in India who are infected. Many of them, particularly students, want to travel and cannot, because until you put it on your list of authorized vaccines, it's not recognized. So when will the WHO do this?
I hope very soon. The Bharat Biotech actually submitted their data third week of July. This was the first data set. There was an updated data set that came in middle of August. The committee has gone back to the company with some questions, which I understand they must be in the process of answering now. I think the technical advisory group that ultimately approves the EUL status of vaccines will meet in the first 10 days of September. And so we are hoping that this will happen soon after that. So by middle of September is what I'm thinking. And the reason it's taken longer is because of the back and forth and the need that for more data that was requested from the company. And this is the usual process. I mean, people think that it's taking longer for Covaxin than for others, but it's not the case. For each company that's applied for the EUL, it's taken this period of about 4 to 6 to 8 weeks to get all the data that's needed to confirm the status.
Has Bharat Biotech been a little slow in providing the details and the data you need? You refer to the back and forth between the committee and Bharat Biotech, the committee asking questions, Bharat Biotech responding. Have they been a little slow? Have they been giving information in dribs and drabs rather than the whole lot at one go?
No, I wouldn't say that. I think perhaps, it took them a bit of time to compile the initial dossier. As I said, it came in the third week of July. But after that, I think they've been very responsive. Bharat Biotech is a company that's very experienced with pre-qualification. And in fact, the WHO regulatory team does not even need to come and do an on-site inspection because they've done that before for other vaccines. So they know the company very well and its quality standards. Whereas for other companies that have never had a WHO pre-qualified product, the team actually travels. Like they traveled to China and visited several of the facilities there to make sure that, the GMP good manufacturing practices were being followed. So in fact, that's not necessary for either Serum Institute or for Bharat Biotech.
But as you said, Bharat Biotech took time to compile the initial dossiers. That's why they were only given to the WHO somewhere in the third week of July. Thereafter, Bharat Biotech has been fairly prompt. It's not been slow.
Yes.
And we can hope that by the middle of September, that's roughly 3 weeks from now, Covaxin will be cleared by the WHO and made one of its authorized vaccines.
That decision will be taken by the technical advisory. It's an independent group. So that decision is not made by me or any WHO staff member. But I'm fairly confident that they will be satisfied.
Thank you very much indeed, Dr. Swaminathan. I'm very grateful for this interview. Take care. Stay safe.
Thank you, Karan.